Good evening, everybody. My topic for today is safety and efficacy of 27-gauge lens-sparing vitrectomy for stage 4 retinopathy of prematurity. I have no financial disclosures. Lens-sparing vitrectomy has been established as the standard of care for stage 4 ROP. It initially started as a 20-gauge system with Dr. Mike Tracy introducing it, but now majority of studies report results with 23 and 25-gauge systems. 27-gauge LSV initial experience has been reported by 2 studies in a very limited number of eyes from Japan and from South India. 27-gauge has potential advantages of smaller incisions, better sealing, and these eyes are as it is smaller, so it may be better for them. There are lesser chances of post-op hypotony and bleeding potentially, and better dissection of the proliferation in ROP with the cutter tip being nearer to the retinal surface. So with these objectives in mind, we tried to evaluate the safety and efficacy of 27-gauge lens-sparing vitrectomy for tractional retinal detachment related to stage 4 ROP. It was a retrospective interventional case series. All patients who underwent 27-gauge lens-sparing vitrectomy for stage 4 ROP between September 2019 and 20 were recruited. Detailed preoperative and intraoperative data recording using standardized performers was already done at the time of the surgery. So this is the performer that we routinely use for ROP surgery, which includes the preoperative features as well as the detailed surgical notes, including those for any complications that are encountered during the surgery, as well as the recording of the surgical times. So the primary outcome measure was single surgery anatomical success rate at 3 months, and secondary were iatrogenic complications such as lens touch or retinal break, wound leakage, requirement of sutures, post-operative hypotony and bleeding, and the surgical times of the entry time and the vitrectomy time. So this is just a representative case as to what was done. This was an 8-week-old infant presented at 40 weeks post-menstrual age, born at 32 weeks. Presented with stage 4B ROP in the right eye and stage 4A in the left eye. Both eyes underwent laser initially, as we do for most cases that present to us prior to surgery. And this is the short video clip of how we go about the 27-gauge lens-sparing vitrectomy. The entry is made at about 1 to 1.5 millimeters from the limbus in the pars pliccata region. And after securing the infusion, the other 2 active ports are made, and you can realize that even with these smaller gauges, the area available is so less that they are abutting the eyelid margin, and you can see the traction that is extending from the optic disc right up till the crystalline lens and actually attaching to the crystalline lens. The objective of ROP surgery basically is to dissect the vector planes and remove the traction, and not do a very extensive surgery of removing the hyaloid and trying to dissect all of the fibrovascular proliferation. So after the ridge to the disc to the lens traction has been removed, the rest of the vitreous is debulked as much as possible around, so that there is no future development of proliferation. And that kind of finishes the surgery, as partial fluid air exchange is done to tamponade the ports, and a majority of the cases we did leave sutureless, as there was no wound leak noted. So this is the same case post-operative 20 days. We can see the right eye that has settled now, and it further settles even better, and the left eye did well just with the laser. So 27-gauge initially had a lot of problem with flexibility, and we were using the Constellation system, but with the introduction of this 27 Plus, which has this kind of 1 millimeter sleeve right at the junction of the shaft and the handle, which reduces the flexibility problem, and this is available with the 10K cutters, and we were very much more comfortable doing the surgery with this rather than the 7500 cuts cutter. So we had 44 eyes of 31 infants. 10 infants underwent immediate sequential bilateral lens-sparing vitrectomy, and the mean age at post-menstrual age at surgery was 42 weeks. Prior to the surgery, laser was done in almost all the eyes, and anti-VEGF was given in 18 eyes, 11 of them as a part of the treatment of ROP, and 7 as part of pre-op treatment when they were vascularly active. And vitreous hemorrhage and pre-retinal bleed were associated in almost 1/4 to 1/3 of the cases, and majority of the cases had more than 6 clock hours of fibrovascular proliferation. Lens sparing vitrectomy could be done in all the eyes with 27 gauge instrumentation. 41 eyes had a minimum follow-up of 3 months and 73% of them had a favorable outcome. The median follow-up was 8 months with a range from 3 to 18 months. Lower gestational age and higher stage at diagnosis were important factors causing unfavorable outcome, and they are present in even for most of the ROP cases. The average procedure time was about 30 minutes and the vitrectomy time was 18 minutes, and sutures were required in about 1/3 of the cases. Complications, there was lens touch in 2 eyes as you can see here, and postoperative fresh bleed, which was the most common complication in about 1/3 of the eyes. But most of them cleared by their own, and only 2 required resurgery for loose blood. And very interestingly, the factors causing loose blood, none of the eyes which had received prior anti-VEGF developed loose blood. So they were independent of the gauge of the surgery used. So coming to the conclusion, 27 gauge appears safe and effective in the management of stage 4 ROP. It provides the advantages of a smaller gauge without compromising on the surgical outcomes. Thank you.
Thank you. Any comments, Dr. Meena?
It's quite surprising to see that with an efficient ROP screening protocol in place, there are so many patients who require surgery.
Absolutely, ma'am. It's still astounding.
And what is the duration of your follow-up for these children?
Ma'am, the median follow-up is 8 months that we have, with a range from 3 to 18 months.
Did any of your children develop cataract during this time, except for the 2 cases where lens touched?
One more patient besides those 2. Both of them developed cataract and ultimately, but that was not in the initial period, so we could monitor them. And ultimately, when they developed cataract, they did undergo cataract surgery. But we did, since there was focal touch in the periphery, we preferred not to do a complete lensectomy at that point of time.
Great, very good study. Just wanted to know, because you said that you document the same ROP for all.
Yes,
Did
sir.
you find difference between 25 and 25 plus? Because theoretically 25 plus, or even we see diabetics, it is more useful.
Yes,
you want to shave. Here your aim is not to shave the vitreous. So
Absolutely.
what added advantage? Because you told outside still it is a big instrument. Inside you are just doing a little bit of truncation. You are not going as membrane peeling which you do in diabetics. So what additional advantage 27
So 25, a lot of, so this is not a comparative study, so I can't make a direct comparison on the basis of this. That is something that we have planned. So 25, a lot of cases require sutures. We were mostly doing a small peritomy in those eyes and then putting the instruments and then suturing them up. That requirement was greatly reduced with 27 gauge, as majority did not leak. So that was the major advantage that we felt with 27 gauge.
Okay.
Can I make a quick comment? It is basically in relation to the suturing in children, because the globe rigidity is so different from the adults.
Absolutely.
Any opening in the eye, it is better to suture rather than to leave it. It is a general impression of an anti-segment surgeon. I think even when you enter an eye with even with a needle or a 1 mm keratome, we tend to close that because they behave totally different from the adults. And even though you mentioned in the video you have not sutured, almost 1/3 of them needed suturing.
Yes, sir.
So it is not that you are avoiding suturing by doing the 20 gauge.
No, ma'am, that is, we are not avoiding. Where it is required, we are definitely putting them. But yes, the need was reduced.
Okay, thank you.
Thank you.